today I'll be talking about a new risk of bias tool. It's kind of new. It's been out for a little, like about a half a year now, a little bit more than half a year. So it's a risk of bias tool for network meta-analysis, and we call it the ROB NMA tool. So for this, we received funding through a 2021 CESH project grant, and we have no conflicts of interest to declare, and I'd like to acknowledge the traditional ancestral and unceded territory of the Squamish, Musqueam, and Tsleil-Waututh nations on which I live, which is, I actually live in Squamish, BC, which is just above Vancouver, British Columbia, Canada. So our steering group for this was myself, Ian White, Julian Higgins, Sophia Diaz, Brian Hutton, RG Veroniki, RG who's here, Jim Wright, Penny Whiting, and Andrea Trico as a senior author. We also had various stakeholders from a lot of organizations helping us to go through the tool and also disseminate it, and as well as a lot of kind of support people and participants who actually joined our Delphi exercises. So we're going to launch a poll right now. So this is a poll. So we actually think we have a few polls to go through, but we'd like to see who our audience is. So if you can kind of go through it right now. And so the question is, what is the primary perspective that you bring to this webinar? So how do you how do you see yourself? What role are you playing in your organization? Here we can see that I guess the majority of people are researchers and academics. Oh. Scroll through. There's a few students, industry representatives, government representatives, and practitioners. So thanks very much for doing the poll with us. And so I'll start the presentation now. So why is it important to assess biases in network meta-analyses? So without a risk of bias tool for network meta-analysis, knowledge users will not be able to tell whether a single NMA is at low risk of bias. So we want to know if it's a low risk of bias NMA. So multiple NMAs are published now, even more than ever, like on the same topic, and choosing from conflicting NMAs is impossible. So I actually have an example here. It's from a study that you can see on the right, and the authors found here 28 NMAs on the treatment for rheumatoid arthritis, and they all had different conflicting results. So we need to be able to choose between them. It's also important for, obviously, HEOR, for government agencies, to be able to assess which is the most, robust, valid NMA. And obviously, if it's at high risk of bias and inappropriate methods are used, the validity of the findings can be compromised, which can impact, patients, treatment and care. So our objectives for developing this tool were basically to develop a tool to just assess the biases. So look at the risks of bias and the results and the conclusions of a network meta-analysis. And we also wanted to make sure that we had good guidance to accompany the tool. So we're going to launch our second poll here. So how long have you, your working group, or your work colleagues been conducting systematic reviews with network meta-analysis? It's okay if you never have. This is supposed to be like a very beginner-friendly presentation, although we will be going through an example at the end, the end of the presentation, although we'll take up a bit of time. So so yeah, it's okay. Whatever your experience is, it's great. And we welcome all different perspectives in your questions as well. So here we have the majority of people, about half, never did an NMA themselves. About 18% conducted one in less than 1 year. Okay, so yeah, it's what we would expect. And then we have 1 to 2 years for the same 18%. Okay. So our methods were, I guess, fourfold. So the first one is we wanted to first do a methodological review to see if there's any items related to biases and network meta-analyses that were out there in the literature already. And we wanted to make a comprehensive list and then look at them and make a decision whether those items should be in our tool. We also obviously added items ourselves and reworded items. So our second was to conduct a survey to ask decision makers about what type of tool they would prefer. So, and also about the structure of the tool. We wanted to make sure that our tool was accessible to decision makers, especially, but to anybody as well. And then we did a Delphi survey once we had all the items in place with NMA experts to select the items to include in the tool. We asked them which ones we should include in the tool, but as you'll see, we ultimately had the last decision. And then finally once we had all the items that we wanted in the tool set up, and we used all these stakeholders to help us put it together, we did pilot testing to draft the tool for usability, efficiency, and comprehension. So our studies were published for for our 2 method studies. So actually this is 3 of our method objectives were in here in the first 2, and then obviously our tool was also published. So you can go to those tools if you want later, and we'll try and put those links actually I could put those links in the chat, or maybe RG can while one of us is talking. Okay, so our third poll. So have you previously conducted quality assessment of a systematic review using Robust or Amstar? So this is obviously a good thing to practice if you've never done it, because it gives you a better understanding of how, biases in systematic reviews, and also, these 2 tools, Robust and Amstar, especially Amstar 2, actually, is linked more to the Prisma. So it is good to just at least do one practice one if you haven't used them before. Okay, so we see that it's across the board. I guess about half of the people have actually used Robust or Amstar 2, so that's great. Okay, and then our fourth poll, have you previously conducted a quality or risk of bias assessment of primary studies? So either here using Cochrane, version 1, version 2, or Robin's Eye. Okay, so the clear winner is yes. 70% of people said yes for multiple studies, actually. So that's what we expected. There's way more people who have assessed primary studies as opposed to systematic reviews. Okay, so moving on to the presentation again. So what do authors mean when they say that they're assessing the quality of a study? So here, quality gets used by authors in all different kinds of ways. And if you've done method studies yourself on assessment of quality or risk of bias, you'll know that. So when you read in a study that the authors assess the quality of the included studies, do they mean that they assess the quality of reporting first, meaning how well the study was conducted, or whether the study was at risk of whether the study was well conducted, so that would be the second one, or whether the study was at risk of bias. So reporting quality is about how well the methods and results in a published study are described, whereas the methodological quality is about how well the research was conducted itself. So it could include, ethics, and also risk of bias is about whether the limitations in a study can potentially bias the methods and findings or the conclusions. So our tool seeks to measure bias only. So whether tools, other tools like, grade, for example, may assess issues related to imprecision or quality and reporting altogether. So we decided, as a team that this tool was only going to be about risk of bias, not about quality of conduct or reporting. So here I wanted to explain what our definition of bias is, and I think it's a pretty, universal definition used by Cochrane as well. So bias refers to a systematic error, meaning that multiple replications of the same study would reach the wrong answer on average. So bias should not be confused with imprecision. Imprecision refers to random error, meaning that multiple replications of the same study will produce different effect estimates because of sampling variation. So imprecision refers to random error, so that each time the trial, each time a trial will take a sample and measure outcomes, they will get a natural variation from the true values in the whole population, so that the smaller the sample size, the more variability and imprecision is generally reflected in the confidence intervals around the treatment effect. So here, for example, the results of small studies with small sample sizes with fewer events, those are less precise and produce wider confidence intervals. So yeah, that's kind of typically that. And then bias is not the same as quality in study conduct. So even a well-conducted study, I think I mentioned, can be at risk of bias. For example, in studies where blinding is impossible, surgery, for example. Or similarly, not all methodological flaws are relevant to bias. For example, failure to perform a sample size calculation, obtain ethics approval. These are all important markers of, quality conduct, but they're unlikely to bias study results. So also bias is not the same as the quality of reporting. So studies rarely report the methods used in great detail, although it is getting better. But studies may have used rigorous methods, but they're just not described in the paper. So they could be, they could be low risk of bias. Okay, so we decided to develop a tool that is intended to supplement an assessment of the risk of bias in an underlying evidence review, which ideally would be a systematic review. So our target would be a systematic review, not a literature review or a narrative review. So as systematic reviews with NMA contain many of the same steps as conducting a systematic review with pairwise meta-analysis, assessors should always start their risk of bias assessment using a tool such as ROBUS or AMSTAR2. And then we used a domain-based structure with signaling statements, which is pretty standard these days. And then our risk of bias tool can be used with on NMAs of all study designs, not just RCT. So it could be observational studies as well. So we also aim to develop a tool to assess both bias in individual NMA results as well as the author's conclusions. So I'll go through this because I think this is maybe a concept that people aren't so familiar with. So network meta-analysis of effect estimates from primary studies can result in overestimation or underestimation of the treatment effects of specific intervention comparisons. So for example, Chaimani and colleagues conducted a network meta-epi study, and they found that in the majority of 32 networks that they analyzed, small studies tended to exaggerate the true effect estimates of the intervention, possibly due to small study effects and publication bias. So our tool focused on first identifying bias in the results of a single NMA. However, bias can also be introduced when interpreting the NMA results to draw conclusions. So conclusions can include the authors spinning, the results or interpretation of the results. So that means kind of, biased misrepresentation of the evidence, perhaps to facilitate publication, because we all know in the past, at least, that statistically significant results always got, or were more frequently published. So here I put that, statistically significant in quotes here. So or erroneous or misinterpretation of the evidence is done, without anybody's, like any kind of malicious intent or, not malicious, but, I guess, desire to publish above all else. So ideally, potential biases identified in the results of the NMA might be addressed appropriately when drawing conclusions. So they can be, drawn like well, which means that you would want to, I guess, talk about a balance of all the results that you were going to be sorry. Ideally, authors should be in their conclusions looking at all the results and not just a subsection of results that might be clinically significant. So similarly, a well-conducted systematic review draws conclusions that are appropriate to the included evidence and can therefore be free of bias, even when the primary studies included in the review itself have high risk of bias. So here, the Rob M&A tool is a single network-based tool. So the assessment tool is applied not at the study or the outcome level, but to a single specific network within a systematic review with a specific numerical result. So just one result. So different networks will often, but not always, correspond to different outcome assessed in the systematic review, and multiple NMAs can be reported for the same outcome. So as examples, multiple networks can be reported for the same outcome due to different scales used, different time points, and sensitivity analyses. So assessing a specific network result is taken because biases in a study could act unequally, and both across the study level and at the outcome level. So working on that network makes sure that we're focusing on that specific thing and assessing bias in relation to it. So here, where does our tool fit in with the framework of different tools for systematic reviews? So we just want to kind of place our tool in this kind of like, I guess, a schematic. So here, this figure illustrates a range of tools used in evidence syntheses involving network meta-analysis. These broadly lie in one or two categories. So typically you'll see in the blue at the top here, we have those two columns. Those typically used by authors conducting systematic reviews containing NMAs. And then on the right, we have those typically used by people that are going to be assessing a completed NMA. So authors of NMAs use a range of tools to guide conduct, interpretation, and reporting. These include tools to assess risk of bias in the included primary studies, such as, Cochrane Risk of Bias version 2, and risk of bias due to missing evidence, for example, Rob ME. Tools to guide completeness in reporting, such as Prisma NMA, and tools to assess the certainty in the evidence, such as Grade NMA or the Cinema tool. So our tool, Rob NMA, is used after authors have published their NMA and when external assessors wants to determine if the authors conducted the NMA in a way that might bias the findings and conclusions. So assessors should use a suitable tool first, as we mentioned, either Robus or AmStar2, ideally, to assess the systematic review portion, and then move on to examine the credibility of the findings from the completed NMA using our Rob NMA tool. So we have developed guidance, and it is it's in our published tool here. We also have more information on the appendices of our published tool. So I kind of encourage you to go and look at it after. And then our guidance explains the background to each of the items, the mechanism of bias, which is new to all these tools, and then how to assess each item based on the response. So this is kind of a snapshot look at the structure of our tool. So first here, there's 3 domains seen on the left. namely interventions in network geometry, effect modifiers, and statistical synthesis. So in total, there are 17 items across 3 domains. Domain 1 contains 4 signaling statements, domain 2 has 4 statements, and domain 3 has 9 signaling statements. Our tool works by using a set of reasonably factual signaling statements to help authors determine bias within these 3 domains. So the range of different responses to the signaling statements are true, probably true, false, probably false, and no information. So true, probably true are considered to be pretty much the same, just expressing different levels of certainty in the response. Whereas no information should be used quite sparingly and only when it's pretty much impossible to make a judgment of yes or no. And authors are encouraged to record their rationale for the response and to provide a direct quote from the NMA itself when they're doing it. So this is practice that hasn't been done, and it just makes it impossible for somebody to transparently reproduce like a risk of bias assessment. So, I mean, that would be a really great methods study is if other authors had actually provided quotes in their rationales and then to see if a methods study did the same, and then to compare the quotes and rationales to see. Yeah, it would just be a better I guess measure of reliability of the tool. Okay, so authors are also encouraged to record their some concerns of judgment replace kind of like unclear risk judgment, which is found in tools like Robust. So we say some concerns instead of unclear here. And then finally, we have the overall judgment, which is rated for specific NMA results and conclusions related to each result. So again, these are judged by the options of no concerns, some concerns, or concerns, which you see at the bottom here in blue. Okay. So we're going to be doing an example assessment by Samara. It's a systematic review here, and it was published in 2020. And it's about the efficacy and acceptability and tolerability of all available treatments for insomnia in the elderly. So remember that some statements can only be answered using the supplements of the papers or the study protocol. So ideally, you would have those 2 things together, the supplements and the protocols, alongside the main study results when you're doing your assessment. So we put the appendix here at the bottom. So just for this, just want to describe this study a little bit more. So their aims were to determine which network of interventions and outcomes you'll have to, decide, for your assessment, which of the NMAs in this systematic review you're going to be assessing, what outcomes you're going to be assessing first. So you'll have to make a hierarchy and then go through that. Here, the authors assessed both pharmacological and non-pharmacological interventions for insomnia. And so for our assessment, what we're going to do is we're going to assess only pharmacological treatments. And the outcome that we're going to assess is total sleep time measured in minutes, and it's a continuous variable presented as mean difference. And in this network meta-analysis, there were 43 randomized control trials identified for this specific network of interventions and our outcome that we're going to be assessing today. Okay, just to let you know too, we don't have time to go through all the items. We only have 45 minutes. So unfortunately, we can't go through all the items, but you can go into our appendix. And this assessment is in our appendix with all the answers, our rationale, and the quotes. So you can go through it at your own pace and take a look at that. Okay, so for domain 1, I'm just going to go through, actually, as I said, some of the domains. RG will also be going through some of them a little bit later on. So for domain 1, there are 4 items. All interventions and their comparators included in NMA are reasonable alternatives for the whole target population. No interventions were inappropriately excluded from the network. Interventions were appropriately grouped into nodes in the network. And then finally, all compared interventions were connected through a suitable chain of within study comparisons. So note here that we're concerned with the comparisons of interventions included in the network and not the study. So it's not like a meta-analysis where we're looking at studies, although it should be looking at outcomes. We're really concerned with the comparisons of interventions here. It's not a study level assessment. It's an assessment at the level of the included intervention comparisons. So these 4 items should be based on the NMA results section of the systematic review and not on the methods section. Well, it will be a bit on the methods section, actually. And then here below, we're just showing what the overall response to the domain would be. So here you would have to choose between low risk of bias, some concerns, and high bias. And it's also really important before you do the assessment that you establish some decision rules about how you're going to be doing these like domain-based assessments at the end and the final judgment at the end as well. And Art Tool and other tools have examples of how to do that, how to set up these decision rules. Okay, so I'm going to talk about item 1.2 first, and that's all eligible interventions were included in the network. So to ensure transparency and completeness of reporting, NMA authors should always make it clear what interventions are eligible for inclusion in the NMA, and also their rationale for why that is. So comparison of the planned for like what we mean by that is what's in the protocol versus the included interventions in the manuscript may reveal inconsistencies when you compare them, actually. And such inconsistencies should be investigated. So NMA authors may provide a list of eligible interventions in the included studies, which ones were excluded from the NMA with a rationale for each decision. So it's important to examine those rationales for exclusion of eligible studies from the network, and so to determine whether the decisions were adequately justified. So exclusions can be reasonable, for example, if they arise from strong concerns about violating the assumptions of the NMA. So I want to just say that because sometimes, studies do exclude NMAs do exclude studies because of the assumption of transitivity being violated. So that can be a justifiable exclusion. And then also wanted to mention that empirical research has shown that exclusion of an intervention, either active or a comparator from a network, can have important impact on estimates of the interventional effects in the NMA and can bias results. So a primary concern here is that interventions can be excluded based on the predicted known effects on the results of the NMA. So we don't want authors to do that. We want to ensure that the results agree with their a priori views right from the get-go. Okay, so and then domain 1, item 1.3. So interventions were inappropriately grouped into nodes in the network. So grouping of interventions or specific implementations of interventions into nodes is often required in an NMA. Sometimes it isn't, but this applies similarly to grouping of control interventions, which include in network, which could include, placebo or no treatment or, control or standard of care, which has, standard of care is in the 1970s is not the same as standard of care in, the 2000s or the 2020s, right? So, those can have very different definitions. So when interventions are grouped together, it's important that they are sufficiently similar so that they're not expected to differ in their relative intervention effects. So bias can arise for the target question if the effect estimated by the combined interventions does not reflect the effect that would be observed if the target intervention, not only those that are combined, have been used. Okay, so here, how did we answer these 2 questions? So for 1.2, we answer, we would answer probably true, since all eligible interventions were included, we believe. So studies included in the review were 77 articles, 76 unique studies reported within those articles, and then there was 21 excluded studies from the quantitative part of the synthesis. So they obviously had reported those outcomes of interest to the authors. And then there was 20 unique studies within that 21 that were going to be used for the quantitative analysis. So for item 1.3, we answer probably true since the interventions were kept as separate nodes, so there was no grouping. However, we do have some grouping. For example, the food supplement, which could be problematic because there's also an intervention node for melatonin. So possibly there's a bit of overlap there, which isn't great. But in general, we're not too concerned because we're looking at the comparisons itself. We also have some concerns because doses were not grouped based on high doses versus low doses. So that is sometimes not an issue, but with some drugs, it may be an issue. And this is where a clinical expert is always needed on the team to be able to advise the team especially about grouping of interventions. However, in general, we are pretty happy with the way everything is. There's not too much grouping in this network, so we answer probably true. Everybody has their own rationale for grouping things, and it's just really important that that is just transparently documented in the manuscript. As long as that's, and the rationale is logical, then that's what we really want to see. Okay, so I'm gonna give the floor over to Archie.
Okay, thank you, Carol. So moving on to domain 2 now, we will focus on the effect modifiers. So overall, in the context of meta-analysis, an effect modifier is a study or a participant-level characteristic that creates between study heterogeneity. In network meta-analysis, this also impacts the transitivity assumption, which requires that the intervention effect measured using an indirect comparison is equivalent to the intervention effect using a direct comparison. So the transitivity assumption holds when the effect modifiers are balanced and similarly distributed across the comparisons in the network. And although we expect that studies in a meta-analysis and network meta-analysis will differ in several ways and due to random error, only a subset of those differences are expected to be true differences and due to the effect modifiers. So variation in the effect modifiers should be kept as low as possible to minimize heterogeneity, and it should be balanced across the intervention comparisons to ensure the validity of transitivity in network meta-analysis. Overall, in domain 2, as you can see, we have 4 items that all relate whether the transitivity assumption holds within the network. And these items are whether the outcome definitions and time points were similar across the different direct comparisons in the network, whether the effect modifying participant characteristics were similar across the direct comparisons in the network, and whether the effect modifying study characteristics now were similar across the different comparisons in the network. And if we answered to those 3 statements or to any of those 3 statements with a false or probably false, then we would also need to answer whether the analysis appropriately addressed those differences in the effect modifiers in the network. And based on what we are going to answer to those 3 or 4 statements, then we are able, again, as Carol said, to summarize those judgments as low, some, or high risk of bias, as you can see in the table presented in the slide. Next. Okay, so now we will focus on the empirical example that Carol introduced and the item 2.2 on the effect modifying participant characteristics, whether those were similar across the comparisons, the direct comparisons in the network. Now, the effect modifying participant characteristics, and similarly for the study characteristics, these can vary across the studies for a particular comparison. And similar to the standard meta-analysis, this would introduce heterogeneity, but also they can vary between comparisons, which will now introduce inconsistency in the network. So if there is an imbalance in the distribution of the effect modifiers between the different types of direct comparisons, then the network meta-analysis is expected to be biased. Overall, the characteristics of participants in the included studies, we would like, ideally, to be sufficiently similar on average across the comparisons that we have in the network. So in this item, we are assessing whether there are systematic differences in known or suspected effect modifying participant characteristics across the the direct comparisons in the network. Some examples that you may encounter as participant characteristics as potential effect modifiers, those can be age, sex, severity of disease, history of treatment, and so on. And here it is important to note that valid indirect comparisons can also be made even if studies differ in participant characteristics, but these should not be effect modifiers. So, for example, if we have an intervention that works similarly in men and women, and we include studies with different proportions of men and women in the different treatment comparisons, then the network meta-analysis and the indirect comparison will still be unbiased estimates of the treatment effects because we don't expect that this is an effect modifier. Next, please. So let's take a look at this illustrative example where we have disease severity as an effect modifier. Focusing first on the standard meta-analysis, we can consider 3 different scenarios depending on the within study and between study variation, and considering whether this is an effect modifier, this is a balanced or imbalanced effect modifier, as we can see the 3 figures. Here we have a standard meta-analysis of 4 trials comparing interventions B and A that included patients with either severe and or moderate disease. So in figure A on the left, we can see that there are no differences in the effect modifier across the 4 studies, and therefore there is no between study or within study variation. So we have people with severe illness in all of the 4 studies. Now in figure 2 or B, in the middle, there are extreme differences in the effect modifier across the studies, and therefore this introduces between study heterogeneity, but not within study variability. And then in the third figure, in figure C on the right, there are some differences in the distribution of the effect modifier across the studies, and therefore there is both within and between study variation in the distribution of this effect modifier. And now, in order to explore within study variability, we would need to access the individual participant data. But moving on now from meta-analysis to network meta-analysis, and on top of these types of variations, we would need to consider potential variability on the effect modifier across the intervention comparisons. So in an ABC network like this one on the right, we have some AB studies and some AC studies, and we're interested in obtaining an indirect comparison between the 2 interventions B and C. So in this case, we would have to consider whether these types of variations, the between and within variations, are similar in the 2 comparisons contributing to this indirect evidence, the B versus C. So for example, if the AB studies include only participants with severe illness and the AC studies include mostly participants with moderate illness, then in that case, the BC indirect comparison of those studies would be an estimate of both severe and moderately ill participants. And if the interventions B and C now are deemed to have different effects in those two types of populations, then the indirect comparison is not expected to be valid. So we would question the transitivity assumption, whether it holds. But if we observe the scenario where the A-B studies appear to be, as in figure C, with between study variability, with between study heterogeneity, and then the same heterogeneity is observed in the AC comparison, then the distribution of the severity across the A-B studies will be the same more or less with the distribution of the AC studies, of severity in the AC studies. So the difference between the pooled estimates of the AB and AC will only be due to the actual difference in the interventions compared. So in this case, where we have similar distributions, we expect that the indirect estimate of the BC comparison will be unbiased. Next, please. Now, going back to the empirical example, the authors assessed the distribution of potential effect modifiers, which were a priori defined, including age, study duration, total sleep time at baseline, and sleep quality. They assessed any important differences between the interventions in these characteristics through the evaluation of box plots, as we can see in this slide. So here, for example, age ranged between 70 and 84 years old. So if we go next, please. There. So the author said that to control for AIDS, they previously set a threshold to include studies with participants above the 65 years of age, and they excluded studies with specific comorbidities as they did not represent the general old patient. Now, as we can see, the authors presented in the paper box plots of the distribution of AIDS and the other effect modifiers across interventions, not the direct comparisons. So we are unable really to determine if there is an overlap of the distribution of the of this effect modifier across the comparisons, and in order to infer whether there is a balance in the network of this effect modifier. And also in the manuscript, the authors report that the few studies available per comparison did not allow for firm conclusions about the absence of imbalance in effect modification, and in most comparisons, only one study was available. So yeah, we need to consider all these aspects. Next, please. Now, and if we click once again. Thank you. Okay, so here the authors assessed for total sleep time at baseline. This ranged between 234 and 432 minutes, showing some variation in the studied interventions. And they mentioned also that they could not assess the distribution of the potential sleep quality modifier since different scales were used by the individual studies. Next, please. Yeah, if we can, yeah. Thank you. Now, based on these considerations, we now are ready to respond to this item 2.2. So we consider that the statement effect modifying participant characteristics were similar across direct and comparisons in the network can be true when the comparisons were similar in known effect modifying patient characteristics, or false when evidence exists of important variation across comparisons in known or suspected effect modifying participant characteristics. So based on what is reported in the publication, we would consider that there is important variation in the participant characteristics in the network, and therefore we would choose false here. Thank you. Next, please. Okay, so now moving on to domain 3, there are another 9 items that we need to consider. So these quickly mention that the highlight whether the analysis was respected the within study randomization, whether there was no publication bias or other selective non-reporting biases, whether we had all predefined analysis in this network with analysis and only those analyses were reported, or if we had any departures explained from the protocol, whether we had biases in the primary studies, whether the methods used to analyze the data handled appropriately the multi-arm studies, whether the authors considered appropriate assumptions about heterogeneity. Then in 3.7, whether there was no evidence of conflict between direct and indirect estimates. And if false or probably false was responded to this item, then we need to address whether this disagreement, the conflicting results between direct and indirect evidence, were adequately considered and dealt in the analysis. And finally, if a Bayesian analysis was performed, then the choice of the prior distributions, whether this was appropriate. Again, based on these responses, we can make a final judgment on the low sum and high risk of bias. Next, please. So the authors here describe in the statistical analysis section, if we click one again. Next, please. Okay, let's open those. Yeah, thank you. So the authors here describe in the statistical analysis section that they performed pairwise meta-analysis and network meta-analysis in a frequentist setting using R packages, meta and net meta. And they use the random effects model, assuming common heterogeneity across the comparisons in the network. So based on this, now we can answer the items 3.1, 3.5, 3.6. If we can open everything, Carol, I think we have a different version now. There we go. Yeah. Okay. So, yeah. So I'll say that in 3.1, we can respond this as true, but that's because they concluded that network meta-analysis, they conduct the network meta-analysis based on a frequentist setting in R, using the packages meta and net meta. And we were also able to answer the 3.9 in the previous slide as not applicable, because they conducted a network meta-analysis in a frequentist setting. Now for the 3.5, here we can respond as a probably true, and that's because there are multi-arm studies in the network, but there was no reporting on this item, so we were unsure whether they correctly entered the data when they used the net meta package, or if they ignored the multi-arm studies altogether. They only mentioned about performing a network analysis in a frequentist setting using the package net meta. We know that the net meta package handles appropriately the multi-arm studies, but it is a matter of describing how they considered this, if they indeed accounted the multi-arm aspect in their analysis or not. And then to 3.6 now, we can respond as true because they applied the random effects model and they appropriately assumed a common heterogeneity across the comparisons in the network. Okay, and then the authors mentioned in the text also that they previously, as we saw previously in the previous slide, that they registered the protocol with Prospero, and they presented the protocol in the appendix. So we can answer the 3.3 as true, because they registered the protocol, they reported the predetermined analysis, and they also explained any departures with appropriate rationales for not conducting any analysis that they planned. So now, going to the item 3.4 regarding the biases in the primary studies, here the authors mentioned that they assessed risk of bias in the included studies in duplicate and independently. They used the Cochrane risk of bias tool. They indicated that studies demonstrated a high risk of bias for sequence generation, as it says here, and allocation concealment. So these studies were excluded from their analysis. And they also conducted sensitivity analysis excluding studies with high risk of bias in blinding, missing outcome data, selective reporting, and other biases. And here, as you can see, they presented also the risk of bias plot across all the studies. Yes, indicating that the mean dropout rate was 8%, but they found high risk of bias for selective reporting in 23 studies, which is the 45%. So we will assess this item, the 3.4, as probably false, And that's because they had high risk of bias for selective reporting in the studies. But we, as assessors, when we assess the specific network meta-analysis, we could not find in the paper any other analysis that dealt with this. And next, please. Now, moving on to item 3.2, where no publication bias or other selective non-reporting biases were suspected, we found in the text that the authors plan to investigate the presence of small study effects and publication bias using the comparison adjusted funnel plot, but they did not provide in the end, as comparisons included the funnel plot, because the comparisons include only maximum 3 studies, and it would not be meaningful. Overall, the authors, as we can see here in the flow diagram, had a good plan. And they mentioned in the appendix that they conducted a comprehensive search, including study registers, pharmaceutical registers, and so on. But they mentioned that they found high risk of bias for selective reporting in almost half of the studies. And they indicated that in their network meta-analysis, there was reporting bias. And that was in a considerable number of studies. And in particular, they said here that in our network meta-analysis, reporting bias was present in a considerable number of studies. So they indicate also that the non-drug interventions were disconnected from the network for all outcomes, which might be an indication for selective reporting. So we assessed this item as probably false because of the reporting bias that was present in half of the studies. Okay, next. Now, moving on to item 3.7, that says there was no evidence of conflict between direct and indirect estimates of the same effect. As you probably are familiar in network meta-analysis, consistency between the different sources of evidence in a network is one of the fundamental assumptions, and a network meta-analysis may not be valid when the direct and indirect evidence are not in agreement. So any conflicts between those two pieces of evidence imply that the transitivity assumption will not hold. And given that consistency is that statistical manifestation of transitivity, we expect that there is agreement between the two, statistically, between the two pieces of evidence. So we need to explore the evidence for such disagreement, let's say potential disagreement in network meta-analysis. Next, please. Okay, so here we can see the network plot that Carol presented earlier on the total sleep time from this empirical paper. We can see that the network plot gives us a good summary of the evidence included in the network analysis. For example, here the authors have presented the size of the nodes according to the number of participants assigned to each intervention. We can see that placebo is the most common comparator, and the active interventions with the most participants here, we can see that these are the rameltion and exoblicon. I'm sorry if I'm not pronouncing this correctly. And also we can see that the edges are also weighted according to the number of studies comparing the specific interventions. Now, focusing on the item 3.7, that says consistency, the statistical manifestation of transitivity can be assessed only when there are closed loops in the network. A closed loop is defined as a set of contrasts for which independent sources of direct and indirect evidence are available. So we are only able to assess for consistency when we have closed loops in the network statistically. Right? So in this network plot, as Carol has highlighted here, there are 3 closed loops, and we can see that we are able to assess consistency in those 3 closed loops. Next, please. Okay, so to answer to this item, we go back to the Samara paper, and the authors mention here that they use the node splitting approach and the design by term interaction model to assess for the consistency assumption. The authors also, though, reported that inconsistency of the network was not measurable since there were no or just 1 or 2 closed loops of evidence in its network. So they concluded that they were unable to evaluate this assumption of consistency, also mentioned as incoherence in the cinema assessment, because they didn't have enough, let's say, evidence. Next, please. Now, overall, for the assessment of consistency in the total sleep time outcome, the authors mentioned that firm conclusions about inconsistency could not be made. If we open everything, Carol, that would be nice. Thank you. So they could not be made, and that's because they only had a few studies available per comparison. So there were just 3 loops of evidence in the network, as we saw earlier. Now, in order to assess this item, we can answer as no information if insufficient data are reported to permit a reasonable judgment to be made. We can answer as false if there is suspicion that a particular closed loop or a particular region of the network, part of the network, has a high likelihood of consistency. We can potentially consider answering as probably false if some evidence of inconsistency exists, but was not serious or important concerns were raised that the tests performed had low power to detect inconsistency. And therefore, considering all this and given what the authors mentioned in their paper, that they could not assess inconsistency because there were not enough evidence, there were not enough studies, and they only had a few closed loops in the network. So considering all these, we would probably answer to this item as probably false. So the reasoning now, the rationale that we make as assessors is that for us, it is unclear if the loops in this network were formed only by multi-arm studies. So if we have only multi-arm studies, that indicates no inconsistency. We have, by definition, consistency. It is unclear to us whether actually why they did not assess for consistency, given that they had closed loops. Even if they had few studies, they're still able to assess. We're still able to assess for consistency. And it is unclear to us if they decided not to assess for inconsistency due to potential low power of the tests, because they had only 3 closed loops and with only few studies, so maybe they wouldn't have enough evidence to adequately, let's say, assess this. And finally, it is unclear if they assessed for consistency, but the results were in conclusion. So these aspects should be reported in the paper. None of these considerations were reported, so to us, this assessment would be probably false. And I'll stop here to pass it over to Carol.
So this is what the Robust tool looks like, and the ROB NMA tool aims to be used in conjunction with the Robust tool to assess a systematic review. So as we all know, like a systematic review is the anchor for all the other either meta-analyses or network meta-analyses that an author group will be conducting. So in our case, we're assessing the network meta-analysis. So, but first, we need to assess that systematic review in order to move forward. So Robust is a comprehensive tool designed specifically to assess risk of bias in systematic reviews. So there is the AmStar 2 tool, but that has a different focus, and it has items related to reporting as well as quality of conduct, not just risk of bias. So since our ROB NMA tool also aims to assess just the risk of bias, we prefer that people use it in conjunction with Robust. And in a previous study that I did, a previous method study that actually just came out, we actually tested Robust with AmStar 2, and we basically found that it takes almost like, the same amount of time to do a Robust assessment as an AmStar 2 assessment. Just actually, robust takes a little bit more thought. So if you want more thought, you should go that way, because it'll make you think more about actually the biases in the review, and that's really the aim of this whole exercise. So, okay. So robust is a domain-based tool. So there's those 4 domains as you see on the top. And this is the first phase. So actually, this is the second phase. This phase 2, actually. So phase 1 is first to assess the relevance. Basically, the extent to which the systematic review's objectives match the research question being asked by the person who's doing the assessment, actually. So the risk of bias assessment. So it would be, so for example, like if you're an overview author who's looking at methods of systematic reviews, or if you're an HTA reviewer, you're going to be, what is your objective? So you're going to be comparing those two and making sure that the PICO and objectives are aligned. And then you would move on to this phase 2 part to identify concerns with the review process. So there's 3 domains that should be considered when you're using robust in conjunction with AmStar2. So first, ROB NMA encompasses the synthesis questions in robust, which we have converted to signaling statements to go with the rest of our assessments. So in robust, the synthesis domain is actually skipped when you use it with ROB NMA. So for robust, each domain contains signaling questions, which the answers are being yes, probably yes, no, probably no, or no information. So when you're finished answering those signaling questions, you make a judgment which indicates if you have concerns about the methods related to each domain, and the responses can be either low risk, high risk, or unclear concerns about the methods that are reported. Okay, so the final phase of our ROB NMA tool, it combines a systematic review level risk of bias judgment using robust first, as you see on the left, with the domain level risk of bias assessments from ROB NMA, which you see in the middle in orange, to determine whether the NMA as a whole is at risk of bias, which you see here on the end in gray. So having answered the signaling questions and statements in ROB NMA, assessors can then indicate if they have concerns relating to each domain. And for robust, those judgments can be low risk, high risk, or unclear concerns, as we said before, and then you consider all of them together. So here at the end, you have to think about whether you want to assess just the results of that systematic review and that specific NMA, that one single NMA that you're looking at, or if you also want to consider the conclusions that the authors had made when interpreting the results. So I think I mentioned this at the beginning of the presentation. The assessors may be interested in whether the results of the systematic review with NMA are at risk of bias, or if the conclusions of the systematic review with NMA are at risk of bias, or both of them. And then, which one they choose, or which one, if they do both, it depends on the purpose of the risk of bias assessment. Okay. And just wanted to kind of recap that an NMA of effect estimates from primary studies can result in overestimation or underestimation of the effects of a specific intervention comparison. So, as we know, bias could be introduced also when drawing conclusions. So I think I mentioned conclusions can include spin, when there's bias misrepresentation of the evidence. Or if it's erroneously interpretation of the evidence, or when there's like an unbalance of, when the authors write up their conclusions, but then they only emphasize, outcome A and B, but then outcomes, C to F are like, not mentioned at all. So potential biases identified in the results of the NMA might be addressed appropriately when the authors draw conclusions, when they, for example, say, hey, we have several limitations. Some of the, these are the biases from our systematic review that could potentially influence the results. And so they write it up in that way where they acknowledge all the limitations. And then a well-conducted systematic review can draw conclusions that are appropriate to the included evidence and can therefore be free of bias even when the primary studies included in the review have high risk of bias. So we recommend that ROBUS be used as it aims to assess biases in the systematic review, although we do acknowledge that other tools like AmStar2 will be used. So there were 21 piloters that assessed an NMA of their choosing using our tool, and we had them choose because then they'll be more experts in, the topic that they chose. And then percentage agreements across the items range from 62% to 100%. So we compared the pilot assessment, so whoever that expert was, and then our team, our expert team, our author group, we then assessed it ourselves, and then we compared those two together. And then the mean time recorded, and this is just for the ROB NMA part. Oh no, actually, it's with Robus actually. So it took anywhere. Oh no, sorry, it is only for ROB NMA. It ranged anywhere between 30 minutes to 150 minutes. So that's like 2 and a bit hours. So we do expect the assessment to take you like at least an hour, probably. Like once you get a hang of it, I've like been doing them in an hour and 5 minutes. So yeah, it will get faster, obviously, but it is important to take your time to record all the quotes to back up your judgments because of course quotes are transparency. So you need those quotes, you need the rationale for why you chose it, especially if the quote is very vague or if there's no quote at all. Yeah. And then, so based on our piloting, we did make a few wording changes. We thought that maybe some of the items were a little confusing when they were read. So we did a little tweaking to item 1.2 and 3.1 in there, and as well in their explanations. So if you'd like to check out our website, our tool, you can actually go to the website. You can also check it out online in the BMJ, but you can go to latitudes-network.org. Okay, so in conclusion, the ROB NMA tool assesses the potential risk of bias by identifying potential limitations in the way an NMA was conducted, including aspects of how the evidence was assembled that may lead to bias in the NMA's either results or their conclusions, or both. Our tool contains 17 items, which are organized into 3 domains, which are interventions and network geometry, effect modifiers, and statistical synthesis. We have developed guidance which explains the background, the mechanism of bias, and how to assess each item based on the responses. And if you'd like to learn more about it, you could go to our link, which is bmj.com, and search for our tool, ROB NMA. So thank you so much for your attention, and we welcome questions.
Thank you very much. Thank you, Carol. Thank you, Areti. I really believe that this is really helpful and it's one more great step towards improving on how we do things. Okay, we don't have much time, but we can take a couple of questions. So, have a question from Rachel, and says that she wondered whether it is sometimes difficult to find the relevant information to assess the items in the various domains, because according to her experience and all our experience, NMAs often produce a huge amounts of results, and they're sometimes reported in a very brief detail.
Archie, do you want to take it?
Sure. I fully agree with Rachel personally. I find that network meta-analysis and in general, the evidence synthesis that we come across are missing important information regarding the statistics and regarding the methods that they have used, and that's usually the problem, because journals require all to describe everything in a condensed manner, right? So in a short, very limited number of words. So it is a problem. We usually have to go to the protocol to see what they describe there. Some of the methods that they were described there are not, again, described in the final publication. We, of course, have to go to the appendices and go through in detail to make sure that they report those aspects there. But I fully agree with Rachel that it is a problem of reporting. As also Carol mentioned earlier, the authors might have done an amazing job in conducting the network meta-analysis, but this might not be there. They might report this in adequate detail. And that's why we are also updating the Prisma for network meta-analysis to make sure we have adequate information for these aspects. But yes, I fully agree. This is something that we are limited, and it takes time to make these assessments. If I remember well, Carol, maybe you can correct me. It took us about more than 1 hour, 1 hour and 20 minutes to go through one of 8 of those network meta-analysis. And that's because we have to assess both the final publication, the protocol, and the appendices. So it is a lot of work. Yeah.
Thank you very much.
Yeah. Can I also add to that, with no information, this is why it's important to have a clinician on your team, because a lot of the time you could actually, even if there's no information, you could you have to really state your rationale, but you can make an assumption. For example, if there's no information about the excluded studies or the excluded interventions, you could actually say, okay, so you can have your clinician come in and say, there's a really important intervention that's missing here, that's not stated in the paper, and it should be in here because, historically, all of these have been assessed. So, you can, use clinical judgment or methodological judgment, but you just have to be very clear about your rationale.
Mm-hmm. Yes, that's important. Thank you very much, both. And okay, we have one more question, which is very detailed, but I will keep only the first part, and maybe we can come back to Yang later. So Yang asks that if is RoBNMA to judge all outcomes or a single outcome? I think we have a little bit discussed this one, but maybe Carol?
Yeah, so you would do one assessment on one network for one outcome for one specific analysis. So, for example, you would, for this insomnia one, we're assessing, sleep time. And then it would be, if there was sensitivity analyses, you would do those separately. So it's one systematic review assessment, but then each NMA gets their own assessment. So you would have to do that.